Hello everyone, welcome back. Today I'll be covering regarding the fracture neck of femur. Start off with an introduction, the anatomy of the neck of femur, what is Watt's triangle, what is Calcar femorale, what is the blood supply to the neck of femur, bone healing in fracture neck of femur, classification of fracture, include Gardens and Pauwels classification, what are the clinical features, and lastly regarding the management. I hope it helps. Now let's get started. As an introduction, usually occur in bimodal age distribution. In a young active patient, is usually due to high energy trauma, either motor vehicle accident or road traffic accident. In our old sedentary lifestyle patient, usually due to low energy trauma, either trivial fall, etc. In older patient, it is higher risk due to osteoporosis bone. The higher risk for dependency and risk of complication of prolonged bedridden, example, deep vein thrombosis, pulmonary embolism, sacrosole, etc. Regarding anatomy of the neck of femur, the neck is connected to the head of the femur with the shaft. It is cylindrical, projecting in a superior and medial direction. It is set at an angle around 135 degrees to the shaft. This angle of projection allows for an increased range of movement at the hip joint. The articular cavity surface takes up only 50% of the femoral head surface. This figure shows the neck shaft angle that we were talking about earlier. Normal usually 120 degree to 135 degree. If less than 120 degree, patient has coxa vara. If the neck shaft angle more than 135 degree, patient has a coxa valga. Among my exam question, what is Watt's triangle? It is a radiological outline of the femoral neck, shows compressive and tensile trabeculae that forms the Watt triangle as a zone of low trabecular density. The importance of the Watt triangle is that it can be used as an initial screening for osteoporosis by using a zinc index. This figure shows the Watt triangle, the zone of low trabecular density. Normal, we can see the primary and secondary compressive group trabeculae more clearly. There's also the primary tensile group and the secondary tensile group. So the Watt's triangle are in between this group. For osteopenic bone, there would be an accentuated trabeculae. There would be an enlarged and indistinct Watt's triangle. Another of my exam question, what is Calcar femorale? It's a vertical reinforcement of the trabecular bone. The Calcar femorale provides stability. Thus, correct reduction of the Calcar femorale is a key factor in achieving stability of construct. With age, the trabecular structure degenerates and concomitantly reinforcement like the Calcar femorale loses the structural integrity. This figure shows the Calcar femorale, whereby it is an important for weight distribution from the hip to the proximal femoral shaft. Usually, if it's disrupted, it can lead to unstable intertrochanteric fracture because the Calcar femorale can act as a buttress against fracture collapse. The subtrochanteric region is proximal 5 cm below the lesser trochanter. Regarding blood supply to the neck of femur, it comes from three main sources: the medial circumflex femoral artery MFCA, lateral femoral circumflex artery LCFA, and obturator artery, I misspelled it, LFCA, okay? In adults, the obturator artery provides little and variable blood supply to the femoral head via the ligamentum teres. The lateral circumflex femoral artery gives rise to the inferior metaphyseal artery by way of the ascending branch and provides the majority of the inferior anterior femoral head. This figure illustrates the blood supply to the neck of femur. You can see the main branch is the medial circumflex femoral artery and lateral circumflex femoral artery. Another one is the artery of the ligamentum teres, or we call it a fibular artery. The lateral circumflex femoral artery can divide into ascending, transverse, and descending branches. So from these ascending branches, it can go into the retinacular arteries, superior, anterior, posterior. Also, the medial circumflex femoral artery can divide and become a retinacular artery that supplies to the femoral neck. The largest contributor of the femoral head, especially the superolateral aspect of the femoral head, is medial circumflex femoral artery. The lateral epiphyseal artery complex comes from the medial circumflex femoral artery and goes along the posterior superior aspect of the femoral neck before supplying the femoral head. The terminal branches supplying the femoral head are intracapsular. Another figure that shows the blood supply of the neck of the femur. Again, our main contributor, the femoral artery, that will be divided into medial circumflex femoral artery and lateral circumflex femoral artery. Then these main branches will again divide to ascending branches of the left medial circumflex artery as an extracapsular arterial ring, and then the subsynovial extracapsular arterial ring by the medial circumflex femoral artery. Bone healing in fractured neck of femur. Bone healing is dependent on the femoral head's vascular supply, which might be easily disrupted by fracture dislocation or increase in intracapsular pressure and cellular coverage of the femoral head, which deteriorates with age, thus limiting osteoprogenitor cell influx following a femoral neck fracture. In adults, only 20% of femoral neck surface is covered by cellular periosteum. The femoral head receives its blood supply from the superior, anterior, and inferior retinacular arteries arising from the deep branch of the medial circumflex femoral artery as well as the round ligament arteries. The development of a post-traumatic femoral head avascular necrosis is highly correlated with disrupted retinacular arteries, which pose as the main blood supply for the femoral head. The retinacular of-weight bridge are intra-articular synovial plicae protecting the retinacular arteries within. In conclusion, poor vascular supply and a limited regenerative potential of the femur next periosteum may cause impaired bone regeneration. Regarding hip fracture classification, based on the location of the fracture, A. Extracapsular or intracapsular. For extracapsular, outside the capsule, it can be subdivided into intertrochanteric and subtrochanteric. For intertrochanteric, which are between the greater trochanter and the lesser trochanter. Subtrochanteric, which are from the lesser trochanter to 5 cm distal to this point. For intracapsular fracture or intracapsular region, from the subcapital region of the femoral head to basicervical region of the femoral neck, immediately proximal to the trochanters. This figure illustrates what we have discussed, whether the intracapsular or extracapsular. For intracapsular, the neck can be divided into subcapital, transcervical or midcervical, and basicervical. For A extracapsular, again, the blood supply to the femoral head is intact. The risk of avascular necrosis is rare. For B intracapsular, that occurs within the capsule of the hip joint, it can damage the medial circumflex femoral artery and cause avascular necrosis of the femoral head. Again, X-ray of the right hip joint that shows the division of fracture or location. We can see the femoral head, the neck region is intercapsular, and the border is the joint capsule, ending by the basicervical fracture. Extracapsular include the GT, lesser trochanter, intratrochanter, that means trochanteric fracture and subtrochanteric fracture. Regarding classification of the fracture of neck of femur, I'm using Garden and Pauwels classification. So this table shows the intracapsular fracture classified by Garden. Type 1 and Type 2 is non-displaced, but in Type 1 is incomplete fracture. Type 2 is complete fracture but non-displaced. Type 3 and Type 4 is a displaced fracture, but in Type 3 is complete fracture but partial displacement. In Type 4 is complete fracture, fully displaced fracture. Okay, good everyone? If not, this figure illustrates more about Gardens. For Type 1 and Type 2 again, fracture is not displaced, but in Type 1 is incomplete fracture, while Type 2 is complete fracture. In type 3 and type 4 is a complete fracture, but type 3 is partial displacement, whereby type 4 is fully displaced fracture. Next, regarding Pauwels classification, Pauwels observed that the obliquity of the fracture line with the horizontal plane significantly affects the prognosis of the fracture. The angle formed by extending the fracture line upwards to meet an imaginary horizontal line drawn through the iliac crest plane on epiphyseum is described as Pauwels angle. The higher the value of this angle, the greater the instability of the fracture. This figure shows the Pauwels classification. Again, the line or angle is formed by the imaginary horizontal line drawn from the fracture line upwards and through the iliac crest plane. For type 1, the angle is less than 30 degrees. For type 2, the angle is around 30 to 50 degrees. And for type 3, the angle is more than 50 degrees. Regarding clinical features, preceded by trauma, patient complain of pain and inability to weight bear. The pain is predominantly in the groin, thigh, sometimes referred to the knee. In elderly, need to investigate the cause of their fall, especially if there is not a clear history of a trip or slip. On examination, the leg is shortened and externally rotated due to the pull of the short external rotators, with pain on pin rolling the leg and axial loading. Please document a full neurological examination. This figure shows the externally rotated limb and shortened that indicate a fractured neck. Regarding management, 1. In children or young adult, close or open reduction and internal fixation with screw or pin. 2. In old patient. This is an algorithm that can help you decide for fractured neck femur, whether it's displaced or non-displaced. In a non-displaced, biologically young, we can do a parallel screw or pins or sliding hip screw. Usually open reduction. But new system we can use right now is femoral neck system. For a biologically young with ASA more than 3, we can do a total hip replacement. For a displaced fracture in frail patient, we can do a unipolar or bipolar hemiarthroplasty. This figure shows a femoral neck system. It's easier to use compared to the last time. This another figure shows the right hip post-total hip replacement X-ray. You can still see the post-op stapler. Yay! We have reached to the end of this video. I hope this video helps. See you in the next one. Take care and bye.